Hi everyone, this is Navdeep here. I am back again with a new topic, which I find can be very helpful for some of my new colleagues, as well as some of the new nursing workforce or nursing aspirants who want to be a part of community nursing team. So we are going to talk about how to admit a client in community nursing service for home support. So not everybody needs a hospital admission to be cared for. So there are a few things that can be managed at home as well if we have proper equipments and supplies with us. So we'll be talking about some detailed information about process of admitting someone who is discharged from a hospital, discharged from acute setting into a community nursing setting. So initially, as for all admissions, we require a referral, and a referral can be from a hospital. For example, if someone is discharged after a surgery, or a referral can be from a GP or a client specialist. For example, if someone has undergone a skin excision for basal cell carcinoma, then they will be requiring wound management for next few days at home, and they don't necessarily need to go back to the doctors for that wound management, so they can be referred to the hospital to the community nursing team. Then these referrals can sometimes be self-referred, like clients can call themselves, because nowadays everybody in Australia probably knows about the phone number for my aged care, or they can find it through their relatives who may be working in a health sector, or they may find it through their doctor. So they can make self-referrals, and these can be for example, if someone who is discharged from hospital with insulin but doesn't know how to manage it, what is a low blood sugar reading, what is a high reading for her or him, and how they are going to manage, especially the devices, because they are often sometimes the hospitals are too busy or the clinics are too busy to educate clients on those kind of things. So they might put in a referral to the home support nurses or community nurses to do that sort of education. So this is what we have to identify when we decide that someone needs an admission in community nursing service. So what's the clinical need for that admission? Does this client have a wound? Is there a urinary catheter in situ that we have to manage at home? Is there any indication for medication management? Is this client taking some high risk medications which he or she is not able to manage at home? Recently, I gave you an example of insulin. There can be many other, like sometimes clients are temporarily put on Clexane injections, so which is enoxaparin, low molecular heparin injections, subcutaneous injections. So sometimes they are not confident to do it for themselves, or they may be osteoarthritis in their fingers, so there can be issue with handling of the device. So we have to identify the need when we go there to admit a client for the first time. Do they have a pigtail drain, which is completely a sterile procedure? Whenever we are dealing with a pigtail drain, then it has to be very strict asepsis, so they can't be doing it themselves at home. So they need a nurse to visit them to do it. And it's not practical to go to hospital every now and then to get the bag changes or to care for the pigtail. So that's why. Sometimes it can be as simple as some sort of education. For example, someone needs an education about how do they change their leg bags for their catheters, urinary catheters. Sometimes it can be an indwelling catheter. Sometimes it can be a suprapubic catheter. So they come out of hospital with bags attached to it, but they don't know what are they going to do with the bag. The bag can't be attached for 20 days. The bag needs to be changed every week at least. So this sort of education we have to go and provide to them. once they are discharged from hospital. Or this can be simply for managing chronic disease, CDM, chronic disease management. The recent example I can give you is someone discharged from hospital with diabetes, which with very fluctuating levels of blood sugars. They have been put on Libre sensor. Libre sensor, if many of you may not be aware of, it's put on the arm, and it keeps active for 14 days and monitors blood glucose levels of someone with diabetes 24/7. So which means they don't have to do their finger pricks all the time to get the blood results for blood sugar levels. So the sensors, they can be just swiped to get the reading at one given point of time. So education regarding sensors, putting the sensors on, downloading the report from the sensors from every 14 days or so. So these kind of chronic disease management things can be done by community nurses. So these are just few examples. There can be many more. So there is some data from Australian Institute of Health and Welfare, and this report has been last updated on 28th of June 2023, which stated that by 30th of June 2022, there were about 213K people using home support services. They were aged 65 and over. So mostly elderly people are the ones who need home services by nurses. So Australian healthcare system can be largely broken down for over 65 years of age. They can be broken down into CHSP, which is a Commonwealth Home Support Program. It's an entry-level program. When we first go and admit the client, they are often given services under this funded program by Australian government. Then comes home care packages. Sometimes when they need a bit more care than what the entry-level CHSP gives, then they can be reassessed by the aged care assessors and they can be given some home care package. There are different levels, level 1, level 2, level 3, level 4, depending on the clinical need, clinical ability, or the functional status of the person. How much services do they need at home? And it covers a lot of things, not just nursing. It can cover assistance with the showers, assistance with the cleaning of their house. So a lot of the non-nursing tasks can be involved. So that's where personal care or support workers can also be involved for caring for someone at home. But mainly nursing, we are talking about nursing only. We are not talking about non-nursing tasks that are covered. So mainly with nursing, there can be people who are on home care packages as well. And once a person needs a bit more care, or if they are deteriorating, they are put, or it's totally the family's decision after consulting with the doctors, and the whole team is involved, whether someone needs to go in the residential aged care, because sometimes all conditions can't be manageable at home. So mainly when we do admissions for home nursing, once we establish the need, we go on to the details of their history. So history involves everything. History is totally a different topic. It's a full-fledged topic. We are not covering those topics. We are just touching on them. So we go into the details of their history, their clinical history, their social history, then finally establishing and documenting the clinical need in our notes, and scheduling some visits for them, and making sure there is availability of equipments that we are going to need. If someone needs assistance with their catheter, we need to organize for the catheters that are delivered to their homes. So nurses, whenever they are visiting them, they should be having enough supplies of all those things. Sometimes family can be involved, sometimes online orders can be placed. Here in Australia, the perspective is totally different. There are a lot of online supply providers that are available for providing home support So we always order through those independent providers, and they deliver the supplies or whatever equipment we need at home, and they can be utilized by the nurses during their visits. And eventually, as the supplies run off, more orders are placed by the nurses who are visiting. So keeping in mind that for any invasive procedure or medications, invasive procedures such as instilling a catheter, instilling a urinary catheter. So we always need valid medical orders. Like we need medical orders to give some medications to someone in hospital. We need medical orders same way in community setting as well. There's no different. To establish the validity of a medical order, every organization will have its own policies and protocols. But if we just talk about the basics, they should have a prescriber's number or provider number on them, which is a Medicare provided number in Australia. It should have signature of the doctor or the prescriber, and the orders should be correct and legible. They should be readable, they should be unambiguous, and most preferably it's preferred that generic name of the medicines are written. But sometimes doctors might not write generic name on the orders. They might write the trade names. For example, the generic name is for a cholesterol medication is rosuvastatin, which is a statin medication, but they may write Crestor on the order. So Crestor is a brand name. So if you are not sure of what medication it is, you can always refer back to AUSDI, Australian Drug Information Drug Directory. It is available online, so we can always refer back to that to confirm brand name and the generic name of the drug. Most important thing is the hazards, because it's not like hospital. You are not going from one client to another client just like that. You are making home visits throughout your day. So there are different hazards. There you have to think about those hazards. You have to document those hazards. Try to document them in your first visit itself, so that the second person or the second nurse who is going there doesn't have to face any issues. For example, if there are pets in the house that need to be locked away when the nurses are there making the visits, then this should be communicated to the client on day one. That, for example, mostly there is a policy with all service providers that pets can't be around when the care is provided. The reason being compromising the aseptic technique of the procedure, compromising the cleanliness of the procedure that we are going to do for that client. That's the reason that mostly pets are kept away, and also for staff safety. So given all those occupational health safety hazards, keeping in mind, we have to document that at our first visit so they are in client's file, clear and legible, reading all those hazards before making any home visits to your clients. So I think we have touched base with most of the things which are required to know as a basic understanding of how admissions go on in a community sector. If you have any queries, please write down in the comment box. We can cover them in the next session or in my next video. Thank you so much.